My name is Benoit Mulsant, and I'm the physician-in-chief at CAMH and also professor and vice chair in the Department of Psychiatry at the University of Toronto. I believe that the main barrier that psychiatrists face in identifying and treating concurrent disorder is the issue of competing priorities or hierarchies of priorities. The same way family physicians, when they see somebody with hypertension, diabetes, and depression, tend to focus on the diabetes and the hypertension. It's not that they are not aware of the depression, it's in the back of their mind and they will do it after, when the other problems are taken care of. Psychiatrists see patients with, for instance, depression and alcoholism, and they will focus on the depression, feeling once the depression is under control, I will be able to treat the alcoholism, which of course is an error, because the depression is not going to be treated until the alcoholism is treated. The patient I saw a few months ago who presented to CAMH, to the hospital, admitted with suicidality and depression, spent 3.5 weeks in the hospital, was treated with antidepressant, and was discharged for follow-up in our clinic. And when I saw her as an outpatient in the clinic, she was not actually doing well. And she became suicidal again, and we readmitted her again. And then on readmission, she finally admitted and revealed that she was probably drinking 1 liter of vodka a day. And of course, she had a major problem with alcoholism. I don't know why or how she didn't go through withdrawal during her first hospitalization, but it illustrates that until that problem was identified and treated, addressing the depression and the suicidality was futile. So during the rehospitalization, treatment for the alcoholism was started in parallel with the continuation of her depression treatment. She was then discharged. The course was, of course, bumpy, but eventually she's now sober and remitted from her depression. From my perspective as a physician-in-chief of CAMH, I think while we are trying to address concurrent disorder, we could do a better job. I think that, as I mentioned, psychiatrists tend to focus too much on the psychiatric problem and to neglect the addiction problem. The addiction group tend to focus on the addiction problem and to neglect the psychiatric problem. And we need to work together to really treat both. Because in people who have concurrent disorder, if you focus on one side or the other of the equation, in the end, you're not going to help them. I work with psychiatry residents, and my advice to them is to learn how to treat simple or less complex addiction problem. And in our field of geriatric psychiatry, that would be alcoholism, addiction to sleeping pills, and addiction to pain pill. I think a geriatric psychiatrist will treat older patients with depression, with bipolar disorder, with schizophrenia, with dementia and other cognitive problems, need to be able to support an older patient who has a drinking problem and need to decrease their drinking or to become sober. They need to deal with patients who are abusing or misusing sleeping pill and pain pill. They also need to think of their patients who are smoking, even though smoking is less prevalent in that group because unfortunately it's associated with premature mortality and medical problems. And so when we see old patients with psychiatric problems, they tend to be survivors and they tend to have less smoking problem than the younger or adult patient with mental health problems.